Okay, we can start now.
Yeah, let me introduce the today's speaker for late Dr. Sambit Mohanty's memorial series. Our today's speaker is Dr. Mahmut Akgul. He has done his medical school from Ankara, Turkey, and he has done his residency in pathology from Cleveland Clinic in 2014 to 18, and then he has done his fellowship in surgical pathology at MD Anderson, and then fellowship in GU pathology in Indiana University. Now he is providing his service as assistant professor in GU-Path at Brigham and Women's Hospital, Boston. And I request Dr. Mahmut to take over the podium. Thank you.
Thanks so much, Dr. Soni, for your kind words and introduction. And thank you so much for the opportunity for this talk. Today, I'm going to discuss oncocytic tumors of the kidney. It was one of the dearest topics for our friend and colleague Sambit Mohanty. If you know Sambit, you know that he was not just a companion, or he was not just a collaborator, but also a companion. He was a close friend, and I think I've known him for about 5 years. And whenever there was an international event that I joined, he was always there. He was extremely active in academic genitourinary pathology. These pictures are from New Orleans, during 2023 ASCAP. And in late September, we also got together. It was the last time I saw him in person, and it was when the European meeting was happening, and we also were both invited to ISAP GUPAT workshop. And it was not only for a academic endeavor, but also we had a lot of fun together. And he was a very dearest, kind human being. And if you know Sambit, you would tell the same thing, and everybody would tell the same thing for him. And he was so active. Actually, his contributions still continue. I just checked the PubMed last night, and as of yesterday, there are at least 13 publications in PubMed after he passed away in January 2025. So I hope we will remember Sambit, dear friend, in any of our genitourinary pathology contributions. Today, I'm going to give a brief and concise review on oncocytic tumors of the kidney, and we should start everything with, of course, the latest classification of genitourinary tumors by WHO. The latest classification was in 2022, and a lot has changed since then, but still we are going to stick to that classification to understand the framework. And after that, we are going to talk about the morphology and morphology-driven diagnostic algorithm on oncocytic tumors of the kidney. And I'm just going to give you a lot of examples, and my talk will be very visual to reach that purpose. So there is a subchapter called oncocytic and chromophobe renal tumors under WHO classification of the kidney tumors. The problem is many kidney tumors can actually present with predominantly eosinophilic cytology. So we are not just talking about oncocytoma or chromophobe renal cell carcinoma. There are other oncocytic tumors of the kidney, low-grade oncocytic tumors, EVT, some kind of tumors seen in patients with Berthold-Dubé. They are called hybrid oncocytic tumors. But also, we should mention clear cell RCC, papillary RCC. We should mention eosinophilic swollen and cystic renal cell carcinoma. We should mention not only epithelial tumors, but also mesenchymal neoplasms, such as angiomyolopomas, which are technically eosinophilic tumors. So my approach to eosinophilic renal neoplasms, of course, it should start with morphology, and we are just going to underscore over and over again, morphology is the king. I start with my evaluation to look for high-grade features. And when I say high-grade, it is not about high-grade, high nuclear grade by WHO. It is, or the WHO ISAP high nuclear grade. I'm talking about high-grade features, meaning increased cytologic atypia, infiltrative growth pattern, desmoplasia, tumor coagulative necrosis, or brisk mitotic activity. If there's no such thing, the second thing I'm looking for is papillary formation. Papillary formation is extremely distinct in kidney tumors, and if you see through papillae, it narrows down your differential significantly. If there's no such thing as high-grade features and there's no such thing as papillary formation, I look for WHO ISAP nuclear grade. If there's low nuclear grade features, predominantly speaking, my differential focuses on certain tumors. So let's look at the overall differential in these scenarios. If I see high-grade features, again, as aforementioned, increased cytologic atypia, when I see an aggressive tumor, which is predominantly eosinophilic, I always think first clear cell RCC. No matter what we do, regardless of our relentless effort to increase the number of RCC, the clear cell RCC will be the most common RCC no matter what we do. It will be 70% of all kidney tumors, and they can present with predominantly eosinophilic features. Epithelioid AML should be one of the differential that we should not miss. They can look like high-grade RCC. And in this list of eosinophilic tumors with high-grade features, there are a lot of tumors that are under molecularly defined renal carcinoma. If there is no high-grade feature, but there is papillary formation, and when I say papillary formation, I'm talking about true fibrovascular cores, we should consider papillary renal neoplasm with reverse polarity or papillary RCC with oncocytic features. If none of those are present, and if there is a tumor with predominantly eosinophilic cytology and low nuclear grade, of course, we should think about oncocytoma and eosinophilic chromophobe RCC. There are some recently identified entities, including low-grade oncocytic tumors, 16-8 dehydrogenase deficient renal cell carcinoma, and others, and we are going to talk about them in detail today. But we should focus on whether the tumor is oncocytoma or eosinophilic chromophobe RCC, because we have the most data and experience on those two particular tumors. We should remember, sometimes you may not have high-grade features, but you may have high nuclear grade in certain tumors, such as chromophobe RCC. Chromophobe RCC actually has innate nuclear atypia that will look like a high nuclear that will look like a tumor with high nuclear grade. There is a tumor called eosinophilic vacuolated tumor. They are notoriously having high nuclear grade tumors, and there are other tumors we are going to mention. Again, having a high nuclear grade does not mean adverse outcome. And speaking of outcome, eosinophilic tumor diagnosis is kind of tricky, because you might have, in this category, you might have no high-grade features or papillae, and you may have low nuclear grade, but you can still have tumors with metastatic potential. One of them is 16-8 dehydrogenase deficient renal cell carcinoma. Low-grade formaldehyde can have metastatic features. And again, we are dealing with a category of tumors with multiple possible clinical outcomes. That's why it makes eosinophilic tumor diagnosis is a little bit intimidating. Regarding of the incidence, most of the incidence in kidney tumors in general are coming from earlier studies, and they might be subject to change. But most of the eosinophilic tumors in kidney are either oncocytoma or chromophobe RCC. I'm not including clear cell RCC with oncocytic features in this category. Otherwise, it will be more than 10% probably. But again, we are talking about 10% of all kidney neoplasms that are predominantly eosinophilic. I told you most of the data are coming from earlier studies, and that earlier studies tend to be contaminated by different entities. For example, you will see in a lot of studies that eosinophilic chromophobe some of the eosinophilic chromophobe RCCs were actually low-grade oncocytic tumors, another recently identified distinct entity. Or you can have a chromophobe renal cell carcinoma that can, or you can have EVTs that might, again, diagnosed as chromophobe RCC. So old data, old incidence data might be a little bit inaccurate. Regardless of the incidence, regardless of the different subtypes, I'm just going to start to introduce you some of the rules that I'm following. When you look at the kidney tumor with eosinophilia first, we should rule out oncocytoma or chromophobe RCC because they are the most common tumors. The second thing is, if the tumor is not oncocytoma or chromophobe, we should rule out clear cell. Again, clear cell RCC is the most common kidney tumor and can be pink. And in eosinophilic tumors and in general in kidney neoplasms, we should consider using at least bare minimum immunohistochemical assays. That bare minimum, the content of that bare minimum will differ from cytology and morphology. Again, morphology is the king. But in eosinophilic neoplasms, KIT, which is CD117, and keratin 7 must be present. I believe diagnostic workup, if the diagnostic workup of eosinophilic kidney tumors doesn't include KIT and keratin 7, it's an incomplete workup. And depending on the context and the morphology, the bare minimum should also include GATA3 and CA9, and I'm going to tell you why I say that in the next couple of slides, or in the following slides. So let's start talking about renal oncocytoma, which is the most common kidney tumor, eosinophilic kidney tumor. And it is the prototypical benign kidney tumor. And these tumors notoriously have dark brown or so-called mahogany color, well circumscribed cut surface. And in about 1/3 of them, you can also have central scar. Slowly growing tumors will have central ischemia, and they will create some hyalinization at the center. That's why you're going to see these star-shaped or central scar. That central scar will be a little bit important for our morphologic evaluation. In microscopic features, there are two main things we should take that into account. One of them is the blend cytology, or tumor cells forming blend cytology and forming varying size of clusters in the background of edematous connective tissue. This is a very strong indication for a possible oncocytoma. Other tumors can have that, but this is a very well-known feature of oncocytoma. Oncocytomas can have packed, diffuse patterns as well, but these edema and these so-called archipelago-like formation is very significant for oncocytoma. We are talking about, blend nuclei, regular nuclear membrane. By the way, oncocytoma can have a lot of nuclei. It should not, refrain you from diagnosing oncocytomas. But you might have some degenerative atypia, or what it is called ancient atypia in oncocytomas, such as focal pleomorphism or pseudoinclusions. You can have clump nuclei. But in general, in overall, when you look at the tumor, you will see very bland, innocent-looking eosinophilic tumor cells. Renal oncocytoma diagnosis should be made in caution, and it should be made with additional immunohistochemical assay support. For example, if you see a mitotic figure in an eosinophilic tumor, you should be really careful calling this oncocytoma. It's a very dangerous thing to do, because oncocytomas should be mitotically inactive. Another thing is, we don't expect too much perinuclear halos in oncocytomas. That is another criterion we use to differentiate oncocytoma from other tumors, such as eosinophilic chromophobe. And so I mentioned about degenerative atypia, and I mentioned about central scar and its impact on morphology. So tumor cells that are stuck in the central scar can have crazy amount of variations in terms of morphology. It can have clear cells, it can have tubules, it can have tubules with mucin formation, and I hope we are not gonna have renal biopsies from those areas. Renal oncocytomas can have what we call atypical features, including perinephric or renal sinus fat invasion or renal vein invasion. That does not make renal oncocytoma worse. According to many studies, including I think it is the latest one, I think, renal oncocytoma with adverse pathologic features involving 50 cases by Dr. Alabaid and Dr. Cheng. None of them had adverse outcomes. All of them were free of disease, and no recurrence or metastasis were identified after complete resection in those tumors with atypical features. Immunohistochemistry, again, I told you the KIT and keratin 7 should be present no matter what we are dealing with in terms of eosinophilic tumors. And in renal oncocytoma, the KIT should be diffusive positive and keratin 7 should be only positive in rare cells. We usually don't expect complete negativity. We are talking about some tumor cells here and there. Older papers talk about less than 5%, I think, but I think 5% is a little bit too much for oncocytoma. Again, very few tumor cells should express keratin 7. You can have entrapped kidney tubules expressing keratin 7. You should also be careful with that. And again, the central scar can impact morphology and immunoprofile. We had a study together with Dr. Sangoi, and you can see KIT can be negative in tumor cells with central scar. Keratin 7 can be diffusive positive. Even CA9 can be expressed. And I told you those tumors can have clear cell cytology. And there's an immunohistochemical assay here. I'm not going to mention its name. Probably in one of the last slides, I'm going to tell you why. There is one single immunostain that can be diffusive positive in central scar. Renal oncocytomas usually have very quiet genomics. They usually have diploid chromosomes. A portion of them are shown to have cyclin D1 gene rearrangement, CCND1 gene rearrangement, but it doesn't mean their survival is bad. That they are also, benign tumors. Another archetypal eosinophilic tumor is eosinophilic chromophobe RCC. These tumors notoriously have perinuclear halo and innate nuclear atypia. This terminology, racinoid, is for eosinophilic chromophobe RCC. Another important feature for these tumors is, I forgot to highlight this, but these linear and sometimes hyalinized vasculature is also important to diagnose not just only eosinophilic chromophobe, but also chromophobe RCC in general. When you look at their immunoprofile, the eosinophilic chromophobe RCC, the KIT and keratin 7 are expected to be positive. The problem is, more often than not, you might lose keratin 7 expression, diffuse keratin 7 expression in eosinophilic chromophobe. You can have partial expression. You can even have oncocytoma-like keratin 7 expression in eosinophilic chromophobe. That's why, let me go back to the morphology. The tumor cells with innate nuclear atypia, perinuclear halo, and these linear/longitudinal vessels with hyalinization should be present to diagnose eosinophilic chromophobe RCC. Eosinophilic chromophobe RCC can have subtypes. One of my favorite subtypes is microcystic pigmented chromophobe renal cell carcinoma. They are formed by predominantly eosinophilic chromophobe RCC cells. and they form small cystic spaces, which is very cute in my opinion. And they have these pigmentations. That pigment is not hemorrhage. When you look at the pigment, it's basically pitch black rather than light brown that we expected to see in hemorrhage or macrophages gobbling up the RBC. Another interesting subtype is neuroendocrine-like features that can be seen in chromophobe RCC. This case is actually I saw this case in my clinical practice when I was in Albany Medical Center, and it was a renal mass biopsy. The renal mass was kind of sizable, 6.5 centimeter, and half of the kidney tumor was eosinophilic chromophobe, and the other half was all neuroendocrine-like, and these areas actually express synaptophysin chromogranin. This study, as far as I remember, this study might suggest that tumors with neuroendocrine features might be associated with worse prognosis, but I don't think that is a settled statement yet. We need more data, and these are extremely rare. Eosinophilic chromophobe again can lose keratin 7. This is a nice example. Actually, this is the example from the previous case with neuroendocrine features. You have diffuse KIT expression, but it is not diffuse keratin 7. So you might have these expression levels, these different expression levels. And on the right side in a biopsy, you can see an example of prototypical oncocytoma in a biopsy. Eosinophilic chromophobe RCC, like chromophobe renal cell carcinoma in general, will have multiple chromosomal losses, but several studies show that multiple chromosomal loss may not always happen in eosinophilic chromophobe. I'm not sure if it is due to the fact that these studies, which are done in 2019, which are relatively old right now, they included LOTs, low-grade oncocytic tumors, which are often mixed with eosinophilic chromophobe RCC. But again, if you want to do cardiogenetic analysis to diagnose a tumor as eosinophilic chromophobe, just be mindful that sometimes they can have diploid chromosome. Another tumor, which is one of my favorite tumors, again, is a low-grade oncocytic tumor. I want to disclose something that I hate the name, because it is probably the vaguest name I've ever had. Like, it doesn't include the etiology of the tumor. It doesn't tell you which organ it is. It can be a low-grade oncocytic tumor from pancreas or thyroid, I don't know, or parotid. I just don't like the name. I hope the experts will find a way to change the name, change the title of this entity. But again, right now, we are all stuck with this name, and everybody knows this entity with this name. So low-grade oncocytic tumor, again, in the past, it was mostly mixed up with eosinophilic chromophobe. Morphologically speaking, it has overlapping features with oncocytoma and eosinophilic chromophobe. You have these not like, archipelago-like, but quote-unquote lace-like or boats in a bay type clusters of tumor cells in the background of this lace-like edema. And most of the time, you will see these diffuse sheets in low-grade oncocytic tumors. Again, like oncocytoma, you shouldn't see any mitotic activity. But unlike oncocytoma and LOT, I forgot to tell you, but eosinophilic chromophobe or chromophobe RCC in general can have mitotic activity. When you go to higher power, these tumor cells in LOT can actually look like liver parenchyma. And it has these interesting cytoplasmic empty vacuoles. There's a recent study done by Dr. Al-Ghamdi, and they actually showed these empty spots were, I think, endoplasmic reticulums. I'm not sure, but they showed that empty spots, these cytoplasmic vacuoles in the using electron microscope in their study. It was an MSK, Memorial Sloan Kettering based study. But again, if in the biopsy, you can have these sheets of low nuclear grade eosinophilic cells with these empty spots. When I see that, I always want to rule out LOT first or diagnose LOT first. And what does LOT2 do in terms of immunohistochemistry? It is kind of mirror image of oncocytoma. It will show a diffuse positivity for keratin 7, and it will be negative for KIT CD117. Luckily enough, these tumors include a lot of mast cells. That's why you can use mast cells as a positive control for your CD117. I'm aware of the fact that CD117 is an extremely difficult stain to read. It doesn't work well. It leaves a lot of background hue. Calling something negative or positive can be difficult at times. Another very useful immunohistochemical assay is actually GATA3. Low-grade oncocytic tumors are arising from the most distal part of the distal nephron. They are arising from a cell type called principal cells, and those cells are positive for GATA3. That's why 100% of low-grade oncocytic tumors will express GATA3. Another marker, and this was the paper that I just mentioned, Dr. Algamdi and his colleagues from Memorial Sloan Kettering. There is also another marker for principal cells in the distal nephron called L1-chem. L1-chem can be positive, actually should be positive in LOT. In this paper, they actually suggest a name change to these tumors as principal cell adenomas, which is not a bad idea, but it is a very humble personal opinion. Another tumor is succinate dehydrogenase deficient renal cell carcinoma, and I believe the presence of this tumor and the fact that it is the only molecular defined renal carcinoma category tumor with predominantly low-grade features, the eosinophilic kidney tumor diagnostics are becoming difficult because these tumors can metastasize even after years of indolent behavior. So, the patient has a SDH-RCC. It is resected. 10 years after this resection, you might have metastasis in these tumors. Another interesting fact about this tumor is they are almost always germline when it is seen in the kidney. So when you diagnose a succinate dehydrogenase deficient RCC in a kidney, you actually diagnose the entire family or potentially the entire family because there will be a germline genetic event virtually always in one of the SDH gene subunits. And the most common one is SDHB in the kidney. These patients usually know what they have from other SDH deficient SDH deficiency related syndromes such as GIST or paragangliomas. And of course, they are usually seen in younger patients. They have a beautiful morphology, including low nuclear grades and some sort of cytoplasmic vacuoles with flocculent material. Unlike LOT, this flocculent material is not empty. They have like pinkish, it's kind of weird, fluid looking thing. It gives you a, I don't know, kind of balloon, like transparent balloon filled with pinkish fluid or something. You can have entrapped normal kidney tubules, similar to oncocytoma or eosinophilic chromophobe or LOT. All, low nuclear grade oncocytic tumors can have these tubules entrapped. Even glomeruli can be entrapped in the tumor, but they are usually well circumscribed. Speaking of different morphology, we did a study recently. We included 40 international SDH-RCC cases. It is probably one of the largest. It's not the largest cohort, but it's one of the largest international cohorts for SDH-RCC. And we found that you can have different morphologic variations in SDH-RCC that can overlap with other tumors. For example, in here, it can actually look like oncocytoma. Another example is LOT. These are from molecularly proven SDH-RCC cases. Another thing is these tumors can have tubular and acinar features. And actually, rarely you can have SDH-RCC with high grade, very aggressive looking features. For example, sometimes succinate dehydrogenase deficient RCC can look like FH-RCC, which is a very aggressive form of kidney tumor. Immunoprofile wise, again, bare minimum KIT and keratin 7, and both KIT and keratin 7 is expected to be negative. KIT should be definitely negative in SDH-RCC, whereas keratin 7 can be rarely positive, but when it is positive, it is usually very few rare cells like oncocytoma-like, expression. SDHB loss by immunohistochemistry is diagnostic and should be present because, as you know, succinate dehydrogenase deficient renal cell carcinoma is part of the molecularly defined renal carcinoma category. And in those tumors, you have to document the molecular alteration. That's why SDH-deficient RCC diagnosis should also include SDHB immunohistochemistry, and it works pretty well. And I told you briefly there are other subunits of SDH gene that can be mutated. SDHB IHC covers them all. So if you have, let's say, SDH-deficient, SDH-A-deficient renal cell carcinoma, you can still use SDHB and it will be negative. In our study, we also show that more than 95% of SDH-RCC also express GATA3, and I think it's a very unique thing, and I think it should be included in our diagnostic workup. When you have a keratin 7 KIT negative tumor with appropriate morphology, if you order GATA3 and it is positive, you are most likely dealing with an SDH-RCC. Another commonly expressed L1-CAM, it was not as positive as GATA3, and it was not as consistent in terms of intensity as GATA3, but you can also have L1-CAM expression in SDH-RCC. We first thought that with these findings, and also we suggested in the paper that maybe SDH-RCC can also arise from principal cells, but Dr. Rahul Mannan and Dr. Rohit Mehra from University of Michigan, they actually found that they might arise from another cell type. I forgot the name, unfortunately, but they might actually arise from another segment from the distal. It is still at the distal nephron, but it's a little bit semantics, a little bit, academic detail. But anyway, GATA3 should almost always be positive in SDH-deficient renal cell carcinomas. Another interesting kidney tumor is eosinophilic solid and cystic renal cell carcinoma. These tumors, almost always are seen in female patients. B, I love the name. They are eosinophilic. They are formed by tumor cells with solid and cystic growth pattern. And in this cystic growth pattern, in this solid growth pattern, you will see not low nuclear grade cells, but high nuclear grade cells, and you can see basophilic stippling. It is called Leishmania-like morphology. It's a very, sensitive for ESC-RCC, but not super specific. Other tumors can do that. And actually, some authors think that basophilic stippling might be a clue for translocation-associated renal cell carcinomas. It's an interesting thing, but anyway. In the cystic area, you will have very large cells with abundant cytoplasm and like exuberant tufting with their cytoplasm to the cystic lumen. Another example from WHO. These tumors express keratin 20. Unfortunately, they are not as dramatic. Keratin 20 expression is not as dramatic as this one. It's a very beautiful example. Usually when we see keratin 20 expression in ESC-RCC, it is that focal, patchy, but it's there. When you look at the eosinophilic solid and cystic RCC keratin 20, you will know that it is there. It is positive. Another tumor is eosinophilic vacuolated tumor, very interesting entity. It was formerly known as high-grade oncocytic renal tumor. But fortunately, we are having a less wake but still wake terminology. These tumors are also almost exclusively seen in female patients, and they are formed by these very high nuclear grade tumors. Like you can have almost FHRCC nuclei in these tumors. Their nuclei is a significant finding, and they form these different size of vacuoles in their cytoplasm. I find differentiating eosinophilic vacuolated tumor from ESC-RCC a little bit hard because their immunoprofile may differ, but may overlap. But in general, eosinophilic vacuolated tumor will be positive with cathepsin K. It's like almost always and diffuse, whereas ESC-RCC, you may not find this diffuse strong expression all the time. It can happen, but it is unlikely in ESC-RCC. Keratin 20 is not expected to be positive in eosinophilic vacuolated tumor. Another marker is CD10. Interestingly, these tumors are positive with CD10, and these tumors are also positive with KIT, and most of the time are negative with keratin 7. So the last couple of tumors that I mentioned are now under the group of tumors that are increasing number. So we have a lot of, especially recently identified, kidney tumors with recurrent TSC mTOR pathway mutations. Eosinophilic vacuolated tumor, ESC-RCC, low-grade oncocytic tumors, and our old friend angiomyolipoma, they all have predominantly mTOR pathway mutations. And any marker that are expressed in the activation of this pathway will be positive in these tumors. One of them is a recently identified GPNMB. This marker is pretty sensitive for tumors with mTOR pathway mutations, but it is not specific, unfortunately, because you can have GPNMB expression in tumors without expected mTOR pathway activation, such as chromophobe. We have seen in here, we started playing with GPNMB immunostain. We have it in clinical practice, and we have seen some tumors can actually express GPNMB without expected mTOR pathway mutation. Another thing is mTOR pathway mutations are actually pretty common as a secondary mutational event in RCC. Therefore, just relying on GPNMB or any marker targeting mTOR pathway might be dangerous. Another tumor is a very rare entity called hybrid oncocytic chromophobe tumor. This hybrid terminology is now only preserved for tumors with patients with known Bertholdt-Dubé syndrome. They basically have hybrid morphology of chromophobe, oncocytoma, LOT, and it is just intermingled. It is, but that meshing is on a cellular level. And immunohistochemistry-wise, you will see the same thing. You will see patchy keratin 7 expression. You will see patchy or checkerboard L1 chem expression in these tumors. These tumors can also express GPNMB, by the way. Another thing is recently, this is a new information. Recently, a set of tumors that are folliculin that have folliculin gene mutation, which is the mutation, which is the germline mutation in Bertholdt-Dubé syndrome. It seems like you can have somatic folliculin gene mutation, and you can have it in kidney tumors, and that kidney tumors can have crazy variation in terms of morphology, such as cystic features or eosinophilic cystic, the eosinophilic solid and cystic RCC type morphology. Another kidney tumors within this differential, again, clear cell renal cell carcinoma should be always in the differential. Fortunately, most of the time, you're not going to be dealing with this kind of predominantly eosinophilic tumors. You will have at least focal clear cells. Even in these, in these limited photomicrograph of a renal biopsy, you can appreciate some clearing in this in this tumors in this tumor cells. And CA9 is a very reliable marker, and you don't expect keratin 7 and KIT expression in clear cell. Although I should correct myself, keratin 7 can be focally positive in clear cell. Actually, it is frequently positive. As annoying as it can be frequently focally positive. But what we might not expect is the diffuse expression of keratin 7 in clear cell. Another tumor is a subtype of papillary RCC, which is called biphasic papillary alveolar renal cell carcinomas. They can be present with eosinophilic / basophilic cytology, but they can they will have a similar immunohistochemical profile as we expect in papillary RCC, including diffuse expression of keratin 7 and racemase. Another one is a acute tumor called papillary renal neoplasm with reverse polarity, exclusively eosinophilic, exclusively low grade, and they have this abdominal localization of the nuclei. Beautiful tumor. They are usually incidentally identified as if it's a papillary adenoma, and they are usually less than 5 millimeter. That, in my personal opinion. I think there are reports of tumors with a couple of centimeters, but these tumors should be usually very small. And they will be positive with keratin 7 and GATA3. GATA3 can again be diagnostic to diagnose these tumors. They are benign, and interestingly, these tumors have recurrent KRAS mutations, which is extremely unusual for renal neoplasms. Interesting. Another tumor that can present with eosinophilic cytology is mucinous tubular and spindle cell carcinomas. They have, although somewhat variable, dual positivity for keratin 7 and racemase. If you have this in situ hybridization marker, VSTM2A, it is known to be extremely specific for mucinous tubular and spindle cell carcinoma. Another thing that you can use, although I don't personally think you should, is you can do karyogenetics and you can show the multiple chromosomal losses. And that multiple chromosomal losses in mucinous tubular and spindle cell carcinoma will be different than chromophobe RCC. These are non-random mutations. I'm not going to count the chromosomes that are lost here, but you will be able to see multiple non-random chromosomal losses that are not seen in chromophobe. Another tumor is AML. Sometimes even classical AML can look like somewhat epithelioid, and if you have fat poor angiomyolipomas, you might think that you are dealing with a eosinophilic renal neoplasm, but they are Pax8 negative, SMA negative. SMA positive. They are keratin 7 and KIT negative, and they will consistently express HMB45 and cathepsin K markers. Sometimes they can show pseudopapillary or micropapillary-like features. They can be misinterpreted as other tumors. Even you can misinterpret them as urothelial carcinoma. I just put that slide to keep that in mind. Again, they are going to express HMB45. I'm sorry. They're going to express HMB45, and they don't express Pax8 because they are not arising from renal tubule cells. Another tumor is very rare thyroid-like follicular renal cell carcinomas that they will predominantly form tubule-like structures. In low power, you can even think of neuroendocrine tumors when you look at these tumors. They will be Pax8 positive, but TTF1 negative. Probably follicular thyroid cancer metastasis might be way more common than these tumors. I never seen one, or I think last year there was one tumor here, but again, it is extremely rare entity, and they have this EWSR1 PATSI1 translocation. I apologize for this HMB45 and cathepsin K expression. It's a typo. They're not expected to be positive for these entities. I apologize. This is a typo. Anyway, these tumors, interestingly, on the top of many interesting stuff, they are cyclin D1 positive. So whenever you see a tumor with mostly eosinophilic and tubular features. Whenever you think of a follicular neoplasm of the thyroid in the kidney, order Paxate, TTF1, and cyclin D1. Paxate should be positive, TTF1 should be negative, and cyclin D1 should be positive. Another tumor is, I hope we will not be able to encounter this tumor. Sometimes, even though we expect FH-RCC to be very aggressive, sometimes a low-grade FH-RCC can happen, and they can look like exactly, I don't know, oncocytoma or LOT. Good luck with that if you have that tumor. And the only thing you can do is to document FH loss in these tumors. High-grade tumors can be pink as well. One of them is, again, Fumarate-deficient renal cell carcinoma. They are associated with mostly eosinophilic tumors with very high nuclear grade and very aberrant nucleoli. Another tumor is TFEB amplified RCC. And TFEB amplified RCC can have different morphology. You should keep that in mind. And epithelioid AML can also present with a high-grade eosinophilic tumors. This is a table. I'm not going to go over with this busy immunohistochemical assay table. If you send me an email address, I can just send this table to you as a wall hanger or something like that. So if you remember a slide with a sensor on it, with a red tape on it, that immunohistochemical assay was actually Wymantin. And if you pay attention, I hope you didn't fall asleep during my talk, you would notice that I didn't even mention Wymantin, because we don't need Wymantin in eosinophilic kidney tumor diagnostics. We don't need Wymantin to diagnose renal tumors. I strongly encourage you to abandon this very old immunohistochemical assay. It's not going to help you in any scenario. Okay, so here's one of the important slides in my presentation. Again, morphology is the first, and we should know what we are dealing with when we look at the eosinophilic tumors, which means we should be cognizant of the morphology and immunohistochemical profile of most common tumors with eosinophilic cytology. And if you think the tumor looks like oncocytoma, chromophobe, or EVT, these tumors are also the only tumors with KIT positivity. So KIT expression will help you to support the diagnosis of oncocytoma, chromophobe, and EVT. If you are dealing with oncocytoma, KIT positivity should be coupled with keratin 7 expression in rare cells. In chromophobe RCC, KIT positivity should be coupled with mostly diffuse keratin 7 expression, although, as I told you, it can be focally lost. And in EVT, KIT should be positive. You should have high nuclear grade, as we talked about that, and then cathepsin K, CD10, and if you have a GPNMB, should be positive. Whereas in LOT, ESC RCC, SDH RCC, and PRNRP, which is papillary renal neoplasm with reverse polarity, KIT negativity should be there. And in LOT, KIT negativity should be coupled with keratin 7 and GATA3 positivity. In ESC RCC, KIT negativity should be coupled with keratin 20 expression, even focally, or GPNMB if you have it. SDH RCC should have negative KIT and almost always negative keratin 7, and it should be coupled with GATA3 expression and SDHB loss. SDHB loss is a necessity to diagnose SDH-deficient RCC at this moment. And papillary renal neoplasm with reverse polarity is negative for KIT and expresses keratin 7 and GATA3. If you have morphologic features that are unusual, if you can't just pinpoint any of those lesions, think about common things with weirdo presentation. And when we talk about common things in kidney, it should be clear cell RCC. Order CA9 and let's see if it is expressed. If it is expressed like diffuse membrane strong expression, you might be dealing with clear cell RCC. In unusual morphologic features, in any kidney tumor, you should take more sections, and maybe in one of the areas, you might have focal morphology that are, recognizable. And again, morphologic variant of a common subtype should be your weirdo tumor, or might be your weirdo tumor, such as, biphasic papillary alveolar RCC that I showed you. Despite all these, if you are dealing with unusual morphology and you are sure that it is no common entity, you should start thinking about molecularly defined renal carcinomas. You should look for rosettes, basophilic stippling. You should look for pigments. You should look for submamatose bodies. And you should also look for high-grade features, because again, molecularly defined renal carcinomas, except SDH-RCC, should be presented with or should present with high-grade features like invasive, invasive growth pattern, or like aberrant mitotic atypia, or something like that. You should think of molecule-defined RCC or epithelioid AML. This is a slide for possibility of diagnosing different entities in limited resource setting. I believe in the biopsy, it is probable or possible to diagnose oncocytoma, eosinophilic chromophobe, or LOT. In the resection, you can definitely diagnose that in limited resource setting. And when I say limited resource setting, I'm talking about the setting having keratin 7, KIT, CA9, GATA3, and racemase. Can you diagnose succinate dehydrogenase deficient renal cell carcinoma in a limited resource setting? No, because you need to, you can have extreme suspicion, like dual negativity for KIT or keratin 7, but positivity for GATA3. You can really suspect that with the appropriate morphology, of course, because morphology is the king, as I told you for like 20 times. But it is impossible to diagnose without SDHB at this moment. Similarly, you cannot diagnose low-grade familial deficient RCC in a limited resource setting. You can diagnose chromophobe in a biopsy, because chromophobe RCC has a very distinct morphology. You can diagnose clear cell RCC. In the resections, you probably diagnose most of the tumors with eosinophilic cytology, except the tumors that in need of additional advanced diagnostic tools like SDHB, FH, or when it is rare, due to the lack of experience, you may not be able to diagnose. You may need to show it to someone who is very experienced in gastroenteropathology, like Dr. Soni. So, but tumors love putting you to your place when you try to generalize them. And I'm going to give you 2 examples, and I'm going to finish my presentation. One of the examples is super recent. Actually, it was from last week. It was Dr. Hirsch, my mentor and my colleague here at Brigham and Women. We saw a tumor. It was a personal consult of hers on a 60-year-old male, 5.3 centimeter renal mass biopsy. So when I'm looking at this biopsy, I'm seeing like, tumor cells with low-grade cytology, clusters, archipelago-like look, edematous background. I would probably call it oncocytoma, by just looking at it. Like I would probably call it like 99.9% oncocytoma. I always order immunostains. I'm kind of paranoid in this, but I would definitely think of oncocytoma. But there's a catch here. This pigmentation is kind of weird, right? I would probably ignore that when I was looking at these, clusters of tumor cells in the background of edematous connective tissue, but pigments are there. Well, the good thing is we also had the resection of this tumor during the same personal consult. And when you look at the resection, you can actually see the real cytology of this tumor, which is like it is predominantly eosinophilic again, but it is predominantly having perinuclear halos, which is very characteristic of eosinophilic chromophobe RCC. And this guy have pigments and cystic changes. And I told you there's a subtype of chromophobe which is called microcystic pigmented chromophobe renal cell carcinoma, and it is probably this, despite the fact that this tumor shows almost oncocytoma-like keratin 7. So this makes things a little bit complicated, and we should always be cognizant about the first rule of surgical pathology, which is morphology first. This tumor is looking like a microcystic pigmented chromophobe renal cell carcinoma, and despite the fact that some areas look like oncocytoma and it stains somewhat like oncocytoma, it is still microcystic pigmented chromophobe renal cell carcinoma. Weird things happen, morphology first. Another interesting tumor is weird tumors exist. And here's an example from the beginning of this year. It's actually, this tumor was not mine. I like partially worked it up and then rolled it to another, one of my colleague here. So it's a 42-year-old male. It's a consult case, 3.3 centimeter renal mass resection, predominantly eosinophilic, but there is something weird. When I look at the low power, I know that it is not oncocytoma, it is not chromophobe, it is not LOT, it is something weird. And when you go to higher power, you will appreciate the biphasic cell population. You will see abundant, like tumor cells with abundant eosinophilic cytoplasm. And then these abundant tumor cells are rimmed with smaller eosinophilic tumor cells. I first thought those were vascular structures, but they are actually tumor cells. And here's a more higher power of this tumor. Again, these cells are not vasculature, they are actually tumor cells. And this biphasic look can manifested itself with immunohistochemical assays. KIT was entirely negative, which excludes a lot of the common tumors. It excludes oncocytoma, it excludes eosinophilic chromophobe. Interestingly, keratin 7 was positive in only those smaller cells, most of the time only in those small tumor cells, like vessel-looking tumor cells. Another thing that kind of make us think about a particular entity was diffuse cathepsin K expression and strong patchy melan A expression. And we sent it for molecular testing, and it turned out to be TFEB rearranged renal cell carcinoma. So usually you don't expect TFEB rearranged renal cell carcinoma as predominantly eosinophilic, but here we are. So this example is for the fact that weird tumors exist, and especially molecularly defined renal carcinomas can do crazy things, including this predominant eosinophilic cytology. And fortunately, this is my last slide. I really thank you for listening to my talk. I think I exceeded my 45 minutes a little bit. I usually exceed my time, for 25 minutes. It's actually a success for me. I really thank you a lot for listening to my talk. I really thank you for being here, and I'm happy to have any of your feedback or your questions. Thank you so much.
Thank you, Dr. Mahmut. It was a nice celebration on eosinophilic renal tumors. There are a couple of questions. If we have time, we can take. We can start with first case in where if there is a resource poor setting, can we omit CK7 and CKIT in case of oncocytoma?
Could you ask the question again?
Can we omit CK7 and CKIT in case of oncocytoma in resource poor setting?
In the poor limited resource setting, I think you have to anyway, but we should make sure that tumor has everything that is needed for oncocytoma, and it doesn't have anything that oncocytoma doesn't have. We should play devil's advocate to diagnose oncocytoma. And even in the resource setting, if you are dealing with a pathology setting that doesn't have any immunohistochemical support, I wouldn't diagnose oncocytoma in the biopsy. I would never do that. And I showed you an example of multicystic pigmented chromophobe renal cell carcinoma with oncocytoma, like exactly oncocytoma looking biopsy. So I would be very, very careful not to diagnose it in the biopsy. But you can diagnose, I think you can diagnose in the resection specimen if everything fits well.
Second question is, can you comment more on papillary renal neoplasm with reverse polarity like papillary adenoma?
I don't have much experience in those tumors, unfortunately. But I know the fact that oncocytic papillary RCC and subsequently oncocytic papillary adenomas exists. And I believe they are different than, they are molecularly and I mean, as an entity-wise, they are different than papillary renal neoplasm with reverse polarity. I believe PRNRP-like papillary adenomas, again, I don't have much experience, but papillary renal neoplasm with reverse polarity like papillary adenomas will not have recurrent KRAS mutations. Otherwise, papillary renal neoplasm with reverse polarity will have KRAS mutations. I don't think we should do molecular testing on those benign tumors. And I don't have much experience on GATA3 expression in PRNRP-like papillary adenomas. Maybe it might help, but I don't have much experience. Another marker that I didn't tell you for papillary renal neoplasm with reverse polarity is L1-Chem. And L1-Chem is always positive in PRNRP. So maybe that marker might be helpful in differentiating PRNRP from PRNRP-like papillary adenomas, if you want to do that.
Another question is, can you elaborate GATA3 positive eosinophilic renal tumors? I think you have covered a lot on this topic.
So GATA3 can be used as a diagnostic / supportive tool for low-grade oncocytic tumor, papillary renal neoplasm with reverse polarity, and SDH-RCC. I can tell you one thing which might be helpful for our audience is if KIT is negative in an eosinophilic tumor, use GATA3 as well, because GATA3 is usually positive in SDH-RCC, about 95%, and is always positive with LOT, and those tumors are both KIT negative.
One more question, that is role of Hell's colloidal ion in chromophobe RCC.
Can you ask the question again, please?
Role of Hell's colloidal ion in chromophobe RCC.
There's no use and there's no need. Most of I think about 90% of classical chromophobes are diagnosable by morphology. Actually, it is one of the rare tumors. Chromophobe RCC is one of the rare tumors that I can diagnose without immunostains. You can do that because they have a beautiful, distinct, very specific morphology that no other tumor does. If you are dealing with eosinophilic chromophobe RCC, KIT and keratin 7 will help you way more than Hale's colloidal iron.
Last question, CK20 negative eosinophilic solid and cystic RCC. Have you seen the case?
I haven't seen that, and I don't think keratin 20 should be a prerequisite for the diagnosis of ESC-RCC, but it's just my personal individual opinion, and I have only seen 2 of them in my practice, and both had positive keratin 20 expression. But I wouldn't be surprised if there are eosinophilic solid and cystic renal cell carcinoma with keratin 20 negativity. I wouldn't be surprised. And keratin 20 expression is not specific for ESC-RCC. TFEB amplified, and I think there are some reports for TFEB rearranged RCC as well. So TFEB amplified and TFEB rearranged RCCs can express keratin 20. Yeah.
I want a last comment from you for molecular study, whether you go for germline mutation or somatic mutation study in case of renal tumors, and how often do you go for molecular studies?
So in our setting, we personally cannot order germline testing. We can just favor that. And when you wanna recommend genetic testing, I personally follow the general rules of what germline or when germline testing should be suggested. One of them is young age presentation. So when you are looking at the renal tumors in general, the 5th and the 6th decade is the most common age group in all kidney tumors, regardless of, I mean, there are some exceptions, but most of the time you are dealing with these renal cell carcinomas or renal tumors in an older age. If you are dealing with a renal cell carcinoma in a 20-year-old, 25-year-old, you should start thinking of A, germline testing, B, molecularly defined renal carcinomas, particularly translocation-associated renal cell carcinomas. If you see a tumor that really looks like SDH-deficient RCC, or if you diagnose a tumor with succinate dehydrogenase deficient renal cell carcinoma, you diagnose that tumor, or if you diagnose a fumarate hydratase deficient renal cell carcinoma, you should offer or you should recommend germline testing because, again, SDH-RCC will always have germline mutation, and FH-RCC can be associated with, especially in the younger age, can be associated with hereditary leiomyomatosis associated renal cell carcinoma syndrome. Or sorry, hereditary leiomyomatosis and RCC associated, or RCC syndrome. Sorry about that. I butchered the name. Another thing is if you have younger age and multifocality, like, you have clear cell in a 30-year-old in a multiple, places, ipsilateral or contralateral, you should think of VHL, for example. Chromophobe RCC can be associated with Cowden syndrome, and papillary RCC has a unique germline setting. There's a papillary RCC germline or papillary RCC syndrome, which is associated with germline MET mutation, and the only organ is affected is kidney, and the MET mutation is associated with this setting, and these patients tend to be young, and papillary RCC tend to be multifocal. Did I answer your question?
Yeah, that's.
I tend to digress a lot. I'm sorry. When I talk about kidney tumors, I'm so happy. My enthusiasm just makes me talk more than the question itself. So I hope I answer your question.
Thank you, Dr. Mahmut. Actually, we have overshooted our time. I'm thankful to Dr. Anandi for giving me opportunity. Over to you, Anandi. Thank you.
Thank you, Dr. Soni, for taking your time off. And thank you so much, Dr. Akgul. I must say this was a very neat and well-structured presentation on this very vast topic. And yeah, we really thank you for taking your time out as well.
Thanks so much. Thanks so much for having me.
Thank you.
It was a pleasure.
Yeah, we're looking forward to many more talks from Dr. Akgul as well. And our next session, I will be just sharing details of that. This is a very special one, I must say. It's 4 of us. We'll be having a case presentation. 4 of Dr. Mohanty's students will be coming together to having a case-based discussion on the 21st of August. So we'll be circulating the flyer and the registration code. So yeah, we look forward to all joining for our lecture on the 21st. Thank you, everyone. Thank you, Dr. Bedi.
So,
Dr. Bedi.
thank you. Thank you.
Thank you.
Thanks so much, and I wish you a good night.
Thank you.
Thank you, Dr. Bedi. Thank you, Dr. Lupo.
Thank you.
Thank you.
Thank you. Thank you, Dr. Bedi. Have a good night.